Hello, APA CVS community once again. This is our second webinar for this month. Again, it is focusing on early career type stuff, clinical navigation. This time we're going to be talking about really how to build your plan each day. We'll talk about how to handle consults and discharge summaries and some of the unique features that go along with that. For the first part, for plan building, the idea is that hopefully you were at the previous webinar last week where we talked about how to think about patients in a systems-based approach. And within each system, we would develop a problem list. And then really for those problems, you can either do diagnostic or therapeutic things for them. And the question is, you're rounding each day, and how do you move the patient's care forward? And the real question or the real answer is you need to learn to ask yourself questions. Your brain is a question answering machine. And if you ask it a question, it's going to give you an answer, right? It might not give you the right answer, and that takes a little bit of time, a little bit of practice, and a little bit of knowledge, insight, and know-how. But if you get into the practice of answering yourself or asking yourself questions, you are going to come up with answers that will move the patient's care forward. If you do not ask yourself questions, then your patients largely are going to languish because you need to actively identify their issues. And so we have this patient here broken into system, broken into problems. And the idea is, what type of questions do you want to ask yourself? So for cardiac, for us, probably the most important system, they have a post-cardiac low cardiac output syndrome, meaning that they have cardiogenic shock associated with the fact that they had an operation on their heart. Maybe it's exacerbated by the fact that they had either acute or acute on chronic heart failure to varying degree for one reason or another. What are you going to do about that? Well, diagnostically, you're getting information about their cardiac output index, their SpO2, and some of their endpoint goals that represent adequate perfusion, such as their lactate and their bicarbonate level and things like that. And you want to look at what type of treatments are they on, what medicinal and what mechanical treatments are they on, what inotropes and what mechanical support. And each of those has side effects, and you have to weigh the risks and benefits of each of those and decide and prioritize where you want to go. And the idea is that, if your output and index is well within the normal range for the amount of support that you're on, then you need to say, am I ready to start the weaning process? And in that situation, the answer probably is yes. And generally speaking, let's assume that they're just on inotropes. You would probably want to start weaning them down on a scheduled basis. Now, in institutions like ours, some inotropes you can have to be in the ICU for, and some inotropes you can be on the floor for. Epi, you need a swan in place because you need to be able to titrate to your cardiac output index and your SpO2 and your lactate. Milrinone, you can have non-titratable and be on the floor, right? And so in cases like that, generally speaking, we would choose to start weaning the epi first. And you wean it to the tolerance of what your endpoint goals are. You want the lactate to stay normal. You want the bicarb to stay normal. Their pH to be normal. You want their output and index and SpO2 to be within the normal range. But if you just walk in the room and kind of look and don't say, is this patient ready to be weaned? Then you're not going to make progress. And now, if they're already on off inotropes and they're just on mechanical support, you can start weaning down the mechanical support. And if you do a weaning trial at the bedside, meaning you turn down the support to almost zero, depending on what their anticoagulation tolerance can take, and you see that their MAP and their heart rate and their blood pressure and everything, it stays fine, you can get an echo and get some extra information that way, and perhaps they're ready for explant. But you have to ask yourself, are they ready to wean or are they ready to come off, whether it's medicinal or mechanical? Same thing for the postoperative vasoplegia, right? So you're going to be looking at their MAP, you're going to be looking at their SVR, physical exam as well, other types of things. But you want to say, the vasopressors have side effects, right? Especially if you have a low volume status, you're going to be clamp down beds, and that's when you end up with poor renal perfusion that's made worse by vasopressors and renal failure, and poor gut perfusion that's made worse by vasopressors. And that's when you end up with ischemic bowel, and poor skin or dermal perfusion that's made worse by vasopressors. And that's when you end up with dead fingers and toes and things like that. And so the idea is that you don't want to leave treatments in place if they're not necessary. And so, as much as you can, you want to wean things down, but you need to ask yourself, am I meeting my physiologic end goals? Are they ready to be weaned down? Which should I wean down first, right? Chest tubes and JP drains, any type of drain you want to look at, and you want to know what your minimum thresholds for removal are, right? And it's not just a numbers game. There's more to it than that. And we're going to spend a lot of time talking about this cardiac section because it's probably the most relevant and most important to us as, cardiothoracic surgical type people. But when you look at a chest tube, yes, you have to look at the volume that's coming out, but you also have to look at the quality of what's coming out. Is it serosanguinous? Is it serous? Or is it sanguinous? Is it blood? If it's blood, even if it's below the threshold to take out, you might not want to take it out. You also want to look if there's an air leak in place. You also want to look to see, is there chyle type leakage, or is there empyema type pus type leakage? You wouldn't want to take it out in those situations. The other thing you have to take into consideration is that if the patient is in renal failure or is going into renal failure, um, people will use their lungs as kidneys and they will diurese into the pleural space. And so if someone's creatinine is on the way up and their urine output is on the way down, and you think that their pleural chest tubes are ready to come out, well, maybe you want to wait until that renal issue is resolved and their function is okay, because you're going to take out the tube, they're going to accumulate effusions, and then you're going to have to put it back, or you're going to have to do a thoracentesis. Um, so, you know, you want to think about a lot of things. You want to think about, are they on the ventilator, right? We don't necessarily like to take pleural tubes out on patients who are on ventilators because if you have an air leak, mechanically ventilated breaths are much larger than spontaneous breaths, and attention pneumothorax can develop at a much faster rate. And so, there are some people who are going to be on the ventilator forever, right? And obviously, you're eventually going to take those pleural tubes out. But if they're going to come out within the next day, maybe the better part of hours to wait on those tubes till they're extubated and then take them out. So you want to ask yourselves these types of questions, right? What is the output? What is the quality of the output? Is there an air leak? What is the renal function? What is their vent status? Are they ready to be taken out, right? With mead chest tubes, we generally like to pull the last mead after your wires have been pulled, right? Because your tubes are a window into the cavity that they are in, right? And so if you pull wires and you start bleeding and develop pericardial tamponade, if you have a chest tube in place, you are going to know about that because you're going to see blood draining. It's also going to be therapeutic. Hopefully, it'll stop you from tamponading, right? Hopefully, it'll act as a drain enough such that you can get to the OR in time. But if you don't have a tube in place, then A, you're not going to know that is happening as fast. You'll probably know it once there starts to be hemodynamic compromise. And you have less that you can do about it at that point or without a drain in place. So the order in which we take things out matters. Same thing with your pacer. Look each day and see what's under the pacer, right? Pacing, although it works, creates a dysynchronous contraction between the left ventricle and the right ventricle. It's not as good as conduction through your native conduction system, right? So conduction through myocardial tissue is slower than conduction through the actual conduction system. So if you can AAI pace someone, fantastic, great. But if you're VVIing someone, that's less so good, right? It's going to affect their cardiac output. So as much as you can, sometimes it's better to accept a slightly lower heart rate if you have a native contraction. And so you want to look each day. If you're pacing someone at 100 and it's giving them this dysynchronous squeeze and you check underneath and they're like 95, well, let them be 95 on their own, right? They're going to be better off. And you also have to think about what is their current antiplatelet and anticoagulation status and what is their future status going to be, right? Because that's going to affect your ability to pull those pacer wires. Now, yes, you can always cut them. But you don't particularly like to cut them, right? Patients come back, they're poking through, they're causing pain and other type issues, and it's an infection risk as well, right? So each day you kind of want to go through and ask these types of questions. And if you actively ask the question, then your brain will come up with an answer. If you don't ask the question, then there's a good chance it's going to be glossed over, right? And so let's move on down. We're not going to hit every diagnosis here, but let's move down to our pulmonary HENT section, right? So each day that you're intubated, you have to ask yourself, well, what is my vent status? Is the patient comfortable? Are they awake? Are they compliant with the vent? Is their gas exchange good? Is their PO2 and the PCO2 good? Is it such that they're on minimal settings? And can they protect their airway? And are they ready to be extubated? Okay, good. Then you've asked questions that might lead you towards extubation. If you ask those questions and the answers are no, the patient's paralyzed and their gas stinks and their x-ray is terrible, and they're going to be intubated for quite a long time, you have to then ask yourself, well, what is my plan going to be? Are they going to get better to the point where I can extubate them in a reasonable amount of time? Or is the amount of time for them to get better so long such that it's now unreasonable to leave them intubated and it's more appropriate to trach them, right? And so, if that's the case, the sooner you can identify that, the better for the patient, right? It's safer for the patient. There's less ventilator-acquired pneumonia risk if you do that. There's less risk of a traumatic extubation if you do that. And you can turn off the sedation and start getting them up and around and rehabbing them. And if they're not going to get better over the course of a month, then what's the point of wasting 2 weeks and letting them sit there in bed if you know that it's going to be a month? Trach them early, right? And there's different schools on whether or not to trach early or trach late. But there are consequences to both choices. But the point is that you want to ask those questions, right? Each day you should be looking at under GeoRenal, what is their volume status and what is your goal for the day? What is it you're trying to achieve, right? Are they autodiuresing? Perfect. You don't need to do anything. Is their urine output not really what it should be? Maybe they need additional assistance. Maybe they've already been getting diuretics and the diuretics haven't really been working despite escalating doses. Maybe they need renal replacement therapy. You want to ask these questions. Same thing with Foley's, right? All a Foley is once people are up and around and mobile, it's an infection risk. Get rid of it as soon as possible. But again, you need to ask that question intelligently. It's not just one concern. It's not just about the infection risk. For guys, they can have BPH and difficulty with urination, right? They may be on Flomax normally. You want to make sure that those things are in place before you take the Foley out. You don't want to take a Foley out, doom them to have urinary retention, and then end up having the Foley need to be replaced again. I've had people where the Foley has been removed. The fact that they have BPH and normally on a Flomax has been ignored. They've gone into severe urinary retention such that they have basically the equivalent of a 20-week, gravid uterus, and meaning that their bladder is all the way up to the umbilicus. And that stretch and pain and discomfort was enough to put them into a hemodynamically compromising AFib. And you know what got them out of the AFib? It wasn't cardioversion, it wasn't medications, it was a Foley. You put the Foley in, the bladder shrunk, and like the catecholamine surge stopped, and so did the AFib. So these things go together, right? GI nutrition. Each day you should be asking yourself, are they ready to advance their diet and move things forward, right? The time period that you leave people NPO, the risk of that malnourished state around 5 days starts to exceed the risk of any type of feeding intervention, whether that's putting in a Dopphoff tube and feeding them enterally with tube feeds or putting in a central line with TPN. But obviously, if you know that they're not going to be able to feed themselves moving forward well before that 5 day time period, what's the point of waiting to 5 days, right? And so this is where asking these questions each day is important because if you don't ask these questions, eventually around day 6 or some 7, someone's going to be like, hey, this guy hasn't eaten anything in about 5 days or 6 days. We got to start tube feeds. Whereas if you asked yourself day one, when is this guy going to be able to eat? Is it going to be before 5 days? No, it's clearly not. Okay, let's start feeding them now. Is there any contraindication to it? No. Good. And your patients will do better then, right? And so that's sort of how you want to think about things. Same thing with venous thromboembolism prophylaxis. Same thing with all sorts of stuff. Lines. Each day you should be counting the lines. This line is day 5. This line is day 3. And if you don't need it, get rid of it, right? All it acts as is an infection risk at that point, right? And you have to balance it with the fact you don't want to get rid of all your lines and then leave the patient in a situation where they have an emergency and now they don't have proper access. You need proper access for the level of care that the patient needs, but you don't need unnecessary or redundant access. That's just going to be problematic for you, right? That's the idea. You want to ask yourself questions about how to move your patients forward, right? And so we spent about a quarter of the hour talking about that, and we're going to move on to some other things here. Um, Discharge summaries. There are a few things if you're doing discharge summaries to include demographic data, the history itself, the hospital summary, and then your disposition, right? And for demographic data, there are things that you need to include. The date of service, meaning the date of admission, the patient's name, the MRN, or the financial number, any consults that have been undertaken during the hospitalization, and then you have to have your primary diagnosis and a list of secondary diagnoses, as well as your final diagnosis. And those things may be different. You may come into the hospital with one understanding of what your diagnosis is and then leave with a different understanding, right? For your history, again, it's basically if you did a good H&P, you've set yourself up to have a good discharge summary. It's your chief complaint, your HPI, your past medical history, surgical, family, social, allergy, sensitivities, and reactions, and then your home meds. Now, with past medical history, keep in mind someone who is recently diagnosed with diabetes is probably different in a very extreme way than someone who has had diabetes for 20 years, right? Someone who had a valve 10 years ago is different than someone who had a valve 2 months ago, right? If they need a reduced sternotomy, the level of adhesions that they have is going to be very significant. There are things that we care about in cardiac surgery that are sort of unique to us. We care about dental health a lot, right? Especially in any patients that have implants, valves, grafts, devices, transplants, oral consults, and dental extraction is very common for us, much more so than other types of surgery or specialties. Vasectomies we care about because of theoretical risk of protamine reaction in men. Um, all of those types of things can be important, right? Now, the hospitalization course, electronic medical records have really made this part a lot easier, right? In the old days, you had to scour the chart and read everything. Now you can copy your previous note forward, which has hospital day 1, 2, 3, 4, 5, and today you're adding hospital day 6, and at the end of it, you can just have your hospital course cut and pasted right there. So it's much less of an issue. You need a list of all the operations that the patient had and all of the procedures that they've had. And so if you think of this ahead of time, it's very easy to keep a running tab within your note, especially with electronic medical records, of things as they happen. The hard part is if you're a single isolated practitioner and you're rounding every day, yeah, you can do this. You know that you need to do it. You're the one who's going to suffer the consequences if it's not done. So it's pretty easy to set yourself up for a good discharge summary. The hard part is managing a team and getting everyone invested in doing all these small little details every single time because they might not be the one doing the discharge summary. And so then they don't feel the pain if they don't keep an active list of every operation and every procedure that was done. The day of DC summary, you have to do a quick summary of the patient's stability, their subjective status, their physical exam, that day's labs, that day's studies, and then their basic and advanced ADLs. And their basic and advanced ADLs are important because that really is what determines, can you go home? Do you need to go home with visiting nursing? Do you need to go home with in-house full-time nursing, or do you need to go to a facility, right? So if you don't have your basic ADLs intact, if you can't eat or drink, but maintain basic hygiene and dressing, elimination, stooling, and urination, and have minimal mobilization, the ability to stand up, you're probably not going to go home. Or if you do go home, you're going to need significant nursing care, right? And so when I tell people, they always ask the question, how long am I going to be in the hospital? When am I going to go home? My response to them is that it's not a timetable, it's criteria based, right? You're not going to have a cabbage and go home in 5 days. You're going to go home when you can eat and drink, when you can poop and pee, when you can walk, when you don't have an acute problem, and when, you're ready to be home without assistance. That's when you can go home, right? And then you may have some physical therapy which visits you, but that's fine. And some people reach that faster than others. Whatever you put into surgery is what you get out of surgery. So if you're bedbound beforehand, you're not going to be doing this too quick afterwards. If you're robust and active beforehand, you'll be robust and active much more quicker afterwards. Your advanced ADLs, that things like finances, transportation, cooking, home maintenance, medication management is probably the most important, is really what's going to determine whether or not you need visiting nursing or not. And so each day, if you're doing floor work, PCU work, whatever you want to call it, you should be asking yourselves and looking at your patients and know what your basic and advanced ADLs are and know if your patients are meeting these. Because if you get to the day that they want to go home and, oh, now I have to set up these different services for the patient, it's too late. Now they're not going home that day. You need to know about it ahead of time, right? So that you can set up adequately for them. And then your disposition, you need your final diagnosis, disposition, where they're going. They need DC instructions, their DC meds, which is going to be different than their home meds, very likely. They need a follow-up date, time, location, instructions, and their discharge condition. Now, there are some things that are mandatory by Medicare, mandatory components of every discharge summary. If you're doing these, you have to include these. If you're not, then that's a problem that needs to be remedied. The reason for hospitalization, which we covered, that's your admitting diagnosis, essentially. Significant findings, any procedures or treatments provided. That's why we maintain a list of all of the operations and procedures that they had. Patient's discharge condition, patient and family instructions, and then the attending physician's signature. So moving on to some other things. For consults, there are some things that are unique to different types of consults that we do. If you do a consult for anyone who has advanced heart failure, whether they're a VAD patient or a transplant patient, there are things that have to be included in your plan per UNOS. And UNOS is the government body which sort of governs allocation of organs. So the proposed surgery for the patient needs to be included, the risks and benefits. And so we have this in a templated form in our note so that we're guaranteed to get the major ones listed every single time. It's already in the note. All you need to do is not erase it, which is not hard to do. Surgical expectations, that how it will improve their health by metrics that are important to this governing organization. So you can read this for yourself and see this is a statement that basically has to be included in your plan. The potential recipient can expect to have an inpatient hospitalization. You have to let them know how long they're expected to be in the hospital, and then you need to let them know how long their outpatient recovery is likely to be. And again, going back to the importance of knowing about your ADLs, when can they expect a normal resumption of daily activity in the form of their basic ADLs, and as well as their advanced ADLs and their sternal precautions when those will be lifted, and then complete restriction removal. All of these things need to be included in your plan such that it's an attestation to the fact that you have communicated this with the patient during your initial consultation. It's a sign that you've given them proper care, right? For VV ECMO consultation, We do certain risk score evaluations. Mainly, we do what's called the RESP score. There's also the Murray score, the APPS score, and the AOI score. And there's also a PaFiO2 ratio score, which we'll look at. And these basically um, tell you about in-hospital survival rates. And for a lot of programs, the threshold for whether or not to put a patient on this type of VV ECMO support, which is basically extracorporeal support or lung replacement, essentially, is based upon whether or not they're going to survive. So whether or not you have a threshold cutoff of 50% or 80%, you're going to accept a REP score of either somewhere above 2 or above 6, right? And you could see the risk factors that go into determining a patient's survivability. Clearly, someone's age, the older they are, the worse their prognosis is going to be in this particular area. Same thing with the Murray score. The Murray score looks at your PaO2 FiO2 ratio, which is a fancy way of talking about how much shunting is going on in your lungs. And so shunting is when you have blood flowing by adequately, but you don't have gas exchange in the alveoli. The blood is just shunting by, not participating in gas exchange. And so if the more diseased your lungs are, the more alveoli units are not participating, the more shunting, the more hypoxia you have going on. There's a 2200 rule, which is attached to the diagnosis of ARDS, which is a good indicator. So if you have a PaO2 FiO2 ratio of greater than 200, you have less than 20% shunting going on. And if you have it less than 200, you have greater than 20% shunting going on. Once you have greater than 20% shunting going on, you are hypoxic enough probably to be in ARDS. That's how bad your lung function is. Right. So you could see how the lower your PaO2 FiO2 ratio is, the worse you're going to do. Same thing that talks about how many quadrants you have infiltrates on your chest X-ray, the amount of PEEP you have, because PEEP increases your compliance, and lung disease of the parenchyma is a manifestation of decreased compliance or manifests decreased compliance. And we talk about the compliance itself as well in the form of this formula. Again, you can see how the score correlates to survivability. Same thing with the APP score, age plateau, and they're talking about your inspiratory plateau pressure, which is when you take a breath and then hold it, and then your PaO2 FiO2 ratio. And again, your scores will correlate to different mortality points. Again, these are the ones that typically are cared about for programs when they decide whether or not patients will be candidates for VV ECMO. Same thing with the age adjusted oxygenation index. And your PaFiO2 ratio primarily just on its own correlates with mortality. And so if you take all these things together, each one has its own, sensitivity and specificity, and, more data points is better than none. Probably the best of these are most utilized is the RESP score. But when you combine all these together, you can find, are these patients above this 50% cutoff? Are they above the 80% cutoff? And when you do your initial consultation and decide whether or not you're going to put them on VV or VA ECMO, a VV ECMO, then that's part of how you do it. It needs to be in your consultation. For VA ECMO, the analogous score is the SAVE score. And there's also what's called the Remember and the Encourage score, and we'll talk about each of these. And you can see here for your SAVE score, it's roughly the same idea. It talks about in-hospital survival, and you can see all the factors that go into it: age, weight, the amount of time you've had that you were intubated, your type of diagnosis, whether it's something that's acute, whether it's chronic, whether it primarily involves the heart, whether it involves other organ systems, and then manifestations of cardiac dysfunction in other systems, and how all those things come together to create a risk stratification score. And again, this can, it's one point. You don't want to be dogmatic about it. You don't want to have a good candidate that otherwise maybe this one instance doesn't have the best score and be like, nope, they have a bad score. They're going to die now. You treat patients, not numbers. So this is a tool to aid and assist you in decision making. It doesn't replace decision making. The Remember score is a specific score that is used in conjunction with the SAVE score, and it predicts 90-day mortality in patients undergoing VA ECMO after they have an isolated CABG if they have post-cardiotomy shock, right? And so we talked about post-cardiotomy, low cardiac output syndrome when we were talking about our plan. And in the scenario in the beginning, when we were looking and we said, oh, they're meeting their cardiac output requirements and their SpO2 requirements and their lactate is okay, and their blood pressure is okay, and probably we can start weaning down this medicine, or we can start weaning down this mechanical support. Well, sometimes the opposite happens and they're not meeting those goals, and despite maximal medicinal support, they're still having a rising lactate and still having extraordinary inotrope needs, such that the complications associated with those levels of medications is almost worse than the benefit that you're getting from them. And if that happens after a CABG, you would want to look at your Remember score in conjunction with your SAVE score, right? Your Encourage score is somewhat similar. This is 6-month mortality risk after an acute myocardial infarction with related severe cardiogenic shock. So these are more like the cath lab type patients, whereas the Remember score is more of the CABG type patient. We deal with both of these in our setting, and again, you can see the parameters that go into this and the mortality risk that goes with it when you're doing your initial consultation. Figuring out these scores can help delineate what your plan is and demonstrates to the reader that you've had deliberate intentionality about the evaluation of the success of what it is you're doing for these patients. So, shifting gears a little bit, talking about documentation in the operating room. So, it's good to be paid appropriately for services rendered. And you want to make sure that, you don't want to not be paid just because the insurance companies don't want to pay you. And so it's important, if your surgeon doesn't do this in their operative note, it's very easy to template. All you got to do is fill something like this in, but describe what it is you're doing, and that justifies the level of billing that you do for, right? So the assistant fee is something like 15% of the surgeon's fee, and a PA can bill for 85% of what a MD assistant would bill for. So it works out that we can take home something like 13.6% of an operative fee. And so if you have an operation that's $10,000, that's $1,360 that you just made for participating in the operation. And if you're doing, 500 cases a year, that's quite a bit of money, probably more than your salary, right? And so you can justify your own existence if you are good about making sure that what you bill actually gets paid for. So this says, and I'll take the time to read it because it's important, the PA provided first assistance in this case since there was no physicians or residents available. The PA assisted in all parts of the case and performed the following functions: prepping and draping, harvesting the vein and artery and coronary bypass procedures, opening the chest, providing clear surgical field and suction by obtaining hemostasis, retracting tissue and providing exposure, suturing and following suture, aiding and placing patients on and off cardiopulmonary bypass, providing irrigation and suction as necessary, closure of vein and artery harvest sites, closure of chest, and participating in sponge and instrument counts and dressing application, right? And so maybe this full thing doesn't apply to every patient every time, but it's much easier to have something like this templated in a note and then they just erase what's not applicable to that case, rather than to have them recite this or to worse type it every single time. But you're more likely to get reimbursed for your services if you do that. Now, there's a special consideration if you work in an institution where there are surgical residents, and it's specifically cardiothoracic surgical residents. So if you just have general residents, general surgery, and they happen to do a cardiac surgery rotation, then this doesn't count. But if you are in a place where there are cardiothoracic surgical residents, hospitals get money from the government to pay for that training. And so in a sense, Medicare sort of feels that, and appropriately so, they've already paid for an assistant. They've paid for this resident to be there. And so to pay for a PA to be there is unjustified and doesn't make sense. There are exceptions to this, and so you need to know these exceptions. And so this statement would be put in conjunction with one of these statements to justify your billing specifically if you are working in a institution where they do have cardiothoracic specific residents. So the exceptions are there is no qualified resident available. The surgeon never uses residents. They only use PAs. They have a private system. They don't participate in the residency system. It's specifically for trauma services because of the emergent nature of the service provided. And then resident services were not the best assistant, right? And so we can go through these and look at them. Basically, since for no qualified resident, I understand the Section 1842 B7D of the Social Security Act generally prohibits Medicare physician fee schedule payment for the services of assistant at surgery and teaching hospitals when qualified residents are available to furnish such services. And this is from here on out the part that's going to be different for each slide. I certify that the services for which the payment is claimed were medically necessary and that no qualified resident was available to perform the surgeries. I further understand that these services are subject to post-payment review by Medicare, followed by this, right? And you could see I never use residents. I certify payment, blah, blah, blah. Where medical necessary, that as a standing rule, I never use residents perform assistance at surgery and services. So you can get paid depending on these situations. Trauma services. Certify the services for which payment is claimed were medically necessary, and that this instance at surgery was specifically for trauma services. And then the last one were medically necessary, and that it is my professional and clinical belief that the available resident services were not the best assistant, right? And so you basically almost have an out in any situation if it's, first of all, these things are all true, that the reason that's selected is true and valid, and that the services provided actually happened. And if you put these things, or if your surgeon rather puts these things in their operative note, certainly it doesn't guarantee payment, but it will certainly increase the likelihood of payment for your services, which is important because you did work and you should be paid for your work, right? So we're going to shift gears a little bit and talk about documentation within brief operative notes as well. So your brief operative note should contain certain things, and certain things are mandatory. Preoperative diagnosis, surgical procedure, and postoperative diagnosis are all necessary to document. And your pre-op diagnosis and your post-op diagnosis might not be the same thing. Or the post-op diagnosis may have additional findings. Sometimes you go into an operation and find out when you're doing a TEE that you have to do more than what was anticipated. And it's important to distinguish, right? Just because you did both a mitral and a tricuspid valve, if you only went in for the mitral, your pre-op diagnosis is just the mitral stenosis or the mitral regurgitation. The post-op diagnosis also has the tricuspid regurgitation, let's say, something like that. But your pre-op diagnosis, your post-op diagnosis, they might not be the same. The surgical procedure, and you want to be deliberate about your surgical procedure. You want to say, first of all, what is your method of access, right? And so, are you doing an open median sternotomy? Are you doing a mini J-type sternotomy, right? For all the thoracic people out there, are you doing a lateral thoracotomy, or are you doing a VAT? Are you doing video-assisted thoracoscopy, right? So how you obtain access to do the procedure is your first documented piece of information. And then what the document or what the procedure is that you performed would be next. For something specific like a CABG, you have to document what is your proximal anastomosis, if there is one, and we'll talk about that in a second. What is your conduit, and then what is your distal anastomosis. So if you're doing a lima to LAD, there is no proximal anastomosis, so that's an in situ lima is your graft, LAD is your proximal anastomosis or distal anastomosis. Now, if you did a free lima, then that would be aorta lima, LAD, right? If you did a vein graft to an OM, aorta vein graft OM. If you branched off that with a radial artery to go to an OM2 for some reason, it would be aorta vein graft, which goes to the OM, T branch involving the radial artery to the OM2. And so you have to say what is your proximal anastomosis, what is your conduit. If there's multiple distal anastomoses, you have to say where your junctions are, what type, and then what is your distal anastomosis. Similarly, for your valves, you should be putting not just MVR, you should be saying, well, is it bioprosthetic? Is it mechanical? And what size? Because that has implications for postoperative treatment, right? And for each diagnosis, there should be a procedure involved, right? If you did a CABG with a left atrial appendage ligation and an encompass clamp epicardial ablation, well, then AFib should probably be in your preoperative diagnosis. Otherwise, why are you doing those surgical procedures, right? So you want your documentation to be cohesive and make sense. Your surgeon needs to be documented, and there is a difference between co-surgeons and assistants. So if you have two surgeons that are in the same specialty doing the same operation, that second surgeon is an assistant. If you have two surgeons that are doing separate procedures within the same specialty, so one person's working on the chest, the other person's working on the groin doing a procedure, then those are co-surgeons. Or if you have two surgeons of different specialties, those are co-surgeons. So you have a cardiac surgeon and you have a vascular surgeon, then they're co-surgeons. Okay. But within the same specialty, in order to be a co-surgeon, you have to be doing a separate procedure. Um, PAs fall under the assistants. You want to list your assistant status. So how many assistants were in the room? So this person was first assistant, this person was second, this person was third. Anyone who scrubbed in is included. You want to make sure that you know who the anesthesiologist was. And, like in our institution, our postoperative notes have drop-down menus for all of these things. So it's very easy. I just click on surgeon and any surgeon that I work with comes up and I go click. Same thing with assistant. My whole team is on there. I go click. Anesthesiologist, any anesthesiologist that comes into the CVOR, their name's on there. Click. You want to denote what type of anesthetic was used. Was it general endotracheal intubation? Was it general with LMA? Was it local monitored anesthesia care? And then you need to know your total ins and outs, your IV fluid, and then your products that were given. Maybe not all of these are given, but you want to know which ones and how much. It's easier to erase things than it is to add things. So ours is templated out, so everything is in here. And maybe we gave some fluid, a cell saver, and a Paxil, and you just quickly erase the rest. Total outs, you have to put your urine output. Did they hemoconcentrate anything on pump? And then what was in the chest tubes when you left the room? Specifically, you have to include an EBL in your brief operative note, and it can't be zero. You can't say none. It has to be a number. You can put 1 cc or whatever, but you have to put some type of number. This can't be excluded or erased. Perfusionist, again, who was your perfusionist? But then what type of cardioplegia was used? Where was it given? Was it antegrade, retrograde given? Was both given? What was the configuration of the type of cardioplegia that was used? And then was it given pure just crystalloid or was it a mixture of blood and crystalloid together? What was your pump time? What was your cross clamp time? If you did circ arrest, what was your circ arrest time and relevant data that goes along with that? For tubes, lines, and wires, there's a whole list here, and not all of these are going to be used on every patient, but they're there for example purposes. The idea is that you always want to designate where a tube goes into a patient, what type of tube and size it is, and where it ends up in a patient, right? Because otherwise, when it comes time for the nurses to pull the tubes, it's going to be an issue. Good, I'm back. I think I froze. So for tubes, lines, and wires, again, I'm just going to say, again, you want to know where it goes into the body, what is the type and quality of the tube, meaning what size and what type. Is it a Blake tube? Is it a traditional chest tube? And then where it ends up. Because otherwise, the nurses won't know, looking at the skin, what tube to pull when it comes time to pull a tube, if you tell them to pull a specific tube. And if you might say, oh, well, they'll document it, oh, they'll put a sticker on it, that does not work. Because one nurse in one shift is going to label them A, B, and C, and one of them is going to call them one, two, and three, and it will totally be miscommunicated. And so if you say the leftmost chest tube in the subcostal area is going into the left pleural space, it's a 24 Blake tube, right? That lets them know this skin area where the tube is going in correlates with what's on the inside. So when someone says pull the left pleural tube, they can look and say, oh, fine. And again, there's this bizarre culture of some people like to cross chest tubes where they'll put it on the right side going into the left and the left side going into the right. I mean, you're just asking for trouble if you do that. And if you do choose to do that, then you clearly need to document where something goes in the skin versus where it ends up in the body. And you may say, this is ridiculous. Where else is a Foley going to go other than your urethra? Well, you can have suprapubic tubes that go into the bladder, and sometimes feeding tubes will be used as Foleys, or Foleys will be used as feeding tubes. And so, how do you know where it's going? Is it going into their bladder, or is it going into their gut somewhere? There's all sorts of things that you just want to be accurate about. For things that are metered or measured, like your endotracheal tube or your gastric tube or your swan, meaning that they have hash marks telling the distance, you want to know how deep it is, right? So if your endotracheal tube is at 22 centimeters at the teeth, when you write this note and you leave the operating room and they get to the ICU and it's now at 28, well, you're probably right mainstem intubated at this point, right? And it's good for people to be able to go back and check. The whole idea is that an op note needs to be completed and on the chart per Medicare guidelines before the patient leaves the room. And it acts as a communication tool um, during the interim period until the surgeon can complete their formal op note. And I would say it acts as a communication tool even beyond that, because there are things that we put in our op notes that not every surgeon is going to put in every op note. I mean, I've read some op notes that are like the patient went to the operating room, we put a valve in them, and like that's it. And so clearly, it's to our advantage and to the patient's advantage and to our team's advantage to be as detailed as we can be. Specimens, you want to document what is the specimen, what type is it, what location did it come from, and what processing type. Are you going for frozen pathology? Are you going for permanent pathology? Are you going for microbiology? Are you going for just identification? But for each specimen, you want to know what is being done with it so that it can be appropriately followed up on, right? You don't want a specimen sent off and it has a malignant finding on it, and then it's not in your note that it was ever sent off. That would be bad, right? Implants, you want to put what is the implant, what is the name, what is the model number? And again, implants may be anything from the valve that you put in to a heart pump to the closure type devices or plates that we use. Findings, it's going to be relevant to the procedure that you do, right? So if you do a valve, you want to make sure that you don't have a paravalvular leak at the end of your procedure, right? If you're doing a bypass and you interrogate the grafts, you want to make sure that you document that there's flow in the grafts, right? If you're doing something like a transplant, you want to make sure that you document that there's no tricuspid valve regurgitation at the end. If you're doing a total artificial heart, you want to document, or lung transplant, that the pulmonary veins are patent. If you're doing in a VAD or an implantable cardiac device, you want to make sure that there's no AI, right? And these are just little tidbit things. There are things that are relevant that you all know about that go with each surgery that you want to communicate. at the time that we left the room, this was not a problem, right? And so if you're doing a vascular procedure on any type of patient, you want to know what their pulses are. Were they palpable? Were they Dopplerable? Were they 1+? Were they 2+? Right? So not just having an absence of pulses is a problem. That's a problem, yes, but a change in pulses is a problem. If I went from 2+ palpable to 1+ Dopplerable, that's a significant finding, right? And if you don't document what your pulses are at the end of the procedure and it changes by the time they get to the ICU, how's the ICU supposed to know unless they can reference your note, right? And unless you signed it out to them. So that's what I mean by findings relevant to each type of procedure, right? Complications is a complicated topic to discuss. Generally, if there's no complications, it's great, put none. I generally will define a complication as an irreversible, unintended outcome. So you might be like, well, we made a nick in the diaphragm and we had to repair it. I don't know if that's a complication. That might be incident to the fact that you were doing redo surgery and had to repair it. And sort of my justification and thought for that is that like you wouldn't be able to bill for that. It would be considered incident to, meaning a part of the procedure. If there is a genuine complication, oh, we were doing this procedure and yeah, we also had to take the spleen out, right? That is a unintended, non-correctable problem that happened. I will generally just leave the complications section out. The surgeon should be able to describe what they happened and what complication exists in their own words, in their own operative report. You don't want to you put something in a legal medical document that's going to send him up the river unintentionally. You might put something that's, you think is benign and is truthful, but then can be used against them in a way that really doesn't represent the truth. So I just leave that alone for the most part. And then disposition. What is the status of the patient? Where did they go? Did you do sign out? Remember, stable is not a condition. Stability denotes a lack of change of condition. So you can be critically stable, right? It means that you're in critical care, but you're not really changing. You're kind of hanging there. You're not getting any worse, right? Um, but you could be doing well and be stable, but state people acute stable with well. I mean, I guess it's a degree of wellness in the fact that you're not getting worse, but you're not getting better either. So stable isn't the best word to use. And then with their condition, you want to put data. You want to document their vital signs, want to document relative hemodynamics. If they're going to continue to be ventilated, if they're not going to be extubated, you want to put their vent settings. You want to put their pacer settings, right? All of these things need to be communicated so that there's a starting point for the ICU team to look at to judge future changes, right? In addition to that, if you have any type of ventricular assist device, there are data points that are unique to each of them. One of the interesting and gratifying things about doing heart failure surgery is as much as it is physiology, it's also technology. And while once you learn the anatomy and physiology, that kind of never changes for the most part, unless there's going to be some major revelation that comes out, the technology is always changing and always evolving. And so in that way, it's continuously stimulating. But it also means that it's a lot to know. And there's all types of things. You can have implanted durable LVADs, you can have percutaneous RVADs, you can have percutaneous LVADs, balloon pumps, and this is just a small amount. If you're doing total artificial hearts, there's a whole set of parameters that need to be recorded for that. And then for ECMO, whether you're doing VA, VV, VAV, combinations thereof, there's information that's relevant to each of those types of surgery. And then if you do a procedure that you're using fluoroscopy, you have to have, per the American Radiation Society of America or whatever, certain documentation parameters within your note. You have to have your cumulative radiation dose. And then there is the dose that is released by the machine, and then there's the dose that the patient's body sees, right? So you need both. You need the fluoroscopy time. If contrast media was used, you need to know what type and what dose, right? And then you have to comment every time on immobilization techniques and safety measures that were used. And this is the type of thing that could be templated within your note. It's written once way ahead of time. And then anytime there's fluoroscopy, you just leave it. If fluoroscopy wasn't used, you highlight it and then you erase it. All right. ALARA is as low as reasonably possible, or as low as reasonably achievable. So that's the idea behind that. And then if you're doing transplants, you need your transplant number, which is going to be important because it's going to link your recipient and your donor together. And then it depends on how the donor organ was transported to you. Was it in a non-perfused state, meaning it was kept cold, or was it in a perfused state, meaning it was on a machine where it was, being supported and warm? You have to diagnose your post-trans or notate your post-transplant ejection fraction, and then what their serologies were for infectious disease type purposes. And you have concerns for your heart transplant patients, and you have concerns for your lung transplant patients. Obviously, if you're doing the left and right, you need both. If you're doing a single lung transplant, you would need either only the left or only the right, right? And then within your note, you need your labs that are ordered so that the ICU knows what to follow up on, studies so they know what to follow up on, and then your dosages and medications, right? So you already listed out your mechanical support parameters. Now you're also listing out your medicinal support parameters, right? And so all of these things should be within your brief op note. What I do when I train people is I insist that as they go around, they write down all of this information, right? Because they need to have this checklist in your mind, not only because it needs to be included in your note, but the fact that it needs to be included in your note is indicative of the fact that you should be looking at this before they leave the room. So when I go to uh, gather information for a patient, I whip out my phone, I take a picture of the VAD, take a picture of the drips, take a picture of the vent, boom, 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 boom. But if when you're starting out, you do that, you can take a picture and not know what information is important, right? And then get to the work desk and sit down in your computer and you have everything there and then fill it in. But that means that you left the room without actually considering whether that information was good or not. You just took a picture of it. So taking a picture is something that you graduate to. The idea is that you want to know these parameters, you want to know to look for them, and to check and make sure that they're in proper space. So we're basically at the end of the hour. That is the end of the discussion. And I hope it was beneficial for you. And I hope to see you next week. These are recorded and they are kept online and are a benefit for members. So if you're not a member of the APA CVS, join. And if you missed anything, or if you want to, look at some of these things and transcribe them so they could be put in templates in your notes, then you'll have access to them. All right. Thank you a lot. Have a good one, guys.